Well, good afternoon, everyone. Glad to be back with you all on this Friday early afternoon, at least if you're on the East Coast, early afternoon. Just really dig into this discussion on race and bone health in America with some of our great experts and our very own data expert as well. I just want to go ahead and thank Mia Keys again for joining us as our moderator. Mia has also had a recent change in employment. She's always with us, but she's now even more with us as she's the new chief of staff to our CBC Health Brain Trust chair, Congressman Robin Kelly. So she's kind of gone full circle as the health fellow to the health policy lead to now the Congresswoman's chief of staff, and our very own health expert that always sort of educates us on Friday. So congratulations, Mia, and I will turn it over to you.
Thank you, Brandon. As always, I'm really excited to be with NMQF, and to your point, I'm even more entrenched. So I'm certain that will just mean we will spend more virtual and in-person time together when the time is right. And otherwise, I'm really excited to be joining today's panel and to be speaking with the panelists. And so first, I just want to give a brief introduction of who we have joining us today. So first, we have with us Dr. Nicole Wright. She's an associate professor in the Department of Epidemiology at the University of Alabama at Birmingham. And her research predominantly focuses on the musculoskeletal epidemiology, particularly osteoporosis. So you can imagine why she would be such a really significant part of our conversation today. Her research also explores bone health outcomes and racial disparities with respect to osteoporosis and its management. And for all of her work, she's been recognized through numerous awards and through different publications in prominent journals. She's able to let the world know what it is that the ways in which her ideas are helping us to better understand osteoporosis. So thank you so very much, Dr. Wright, for joining us today. We also have with us, as Brendan mentioned, NMQF's own data analyst, Stair, who works with the index development in support of health equity advocacy, of policy, of different operational work through NMQF, including ways to build more representative clinical trials, more equitable clinical trials. Taylor also oversees NMQF's data infrastructure resources. And we couldn't have this conversation today with respect to osteoporosis and the different inequities and such without Taylor's contribution. So thank you, Taylor, for what you're bringing to the conversation today. And last and certainly not least, we really appreciate Shannon Finley, who is a founding partner of Counsel, for joining us today. She's worked for well over 20 years in policy and strategy across the DC area and on issues ranging from politics to health to tax. And she's able to just bring all of that today as we talk about different legislative efforts and also some things that are coming down the pipe with respect to policy and osteoporosis. So thank you, Shannon, for being here. Thank you to the three of you. I want to turn it over now to Dr. Wright to just bring us through a brief overview of osteoporosis. And then we're going to go and talk a little bit about the data. So Dr. Wright, I'll turn it over to you.
All right, thank you, Mia. And so we're just going to set the stage a little bit about osteoporosis, what it is, and how it is diagnosed. All right, so osteoporosis is a metabolic bone disease that is characterized by low bone mineral density and structural deterioration. And so we put this picture here, and as you can see on this panel, we have normal bone, where the inner portion of the bone, which is called the trabecular bone, is nice and tight and dense. And the outer portion of the bone, which is called the cortical bone, which is not pictured, is also very dense. When you get to the stage of osteoporosis, which is pictured on this panel, you see that inner portion of the bone is now less dense. You see sort of this honeycomb pattern, and also with the outer portion of the bone, it can also thin. And so you can see how this could lead to bone fragility and an increased susceptibility to fractures. With respect to screening for osteoporosis, the test that is used is a dual energy X-ray absorptiometry machine. It is pictured here, so it's a quick and easy test. You lie down and the machine just sort of scans over your body. The sites of interest for osteoporosis include the femoral neck of the hip, so this small portion of your femur bone, and then the lumbar spine region. Based on national guidelines, women who are 65 years in age and older are recommended to be screened for osteoporosis. Younger women who have risk factors for osteoporosis can also get screened. And the evidence in men is a little lacking. And so right now it's around men 70, 75 years or age or older should get screened. And so from this test, it will give you your bone mineral density in grams per centimeter squared, and it will reference it to a standardized population, which is a 20 to 29 white female population, to give you a T-score. And based on that T-score, will you get the actual quote unquote diagnosis of osteoporosis. And so if your T-score is minus 2.5 or below, so meaning you have, say, less than 25% less bone than the young normal population, then you meet the clinical definitions for osteoporosis. The World Health Organization set up the definition back in 1993 using the estimates based off of femoral neck. Clinically, you can either have meet this definition if you have a T-score minus 2.5 at the femoral neck or the lumbar spine, and as well as if you had a hip or prior spine fracture, irrespective of what your bone mineral density is. And I know there's a lot of misconceptions in terms and things around osteoporosis, osteoarthritis. Osteoarthritis is around your joints. Osteoporosis is the bones. There's also this term osteopenia, which is sort of that middle range where we call low bone density, where your T-score is between -1 and -2.5, where you're sort of, you're losing bone, but you have not quite met that definition of osteoporosis. And based off of national estimates, there are 10.2 million Americans with osteoporosis, representing about 27% of women 65 and older, and about 6% of men 65 and older. So why is this important? And the main reason is because of fractures. Fragility fractures are severe outcomes. There are about 2 million fractures annually in the United States. Hip fractures are the most serious, whereas spine fractures are the most common. They are very costly to society. Back in 2005, it was estimated between $14 and $20 billion, and it's estimated to increase to about $25 billion, and maybe even more given the increase in the 65 plus population. And it's also important because fractures have been shown to increase your risk of mortality, as well as decrease your quality of life. So studies have shown that following a hip fracture, 1 year mortality increases by 25%. And that is more common in people of color, have even a higher 1 year mortality following a hip fracture. And then things around quality of life, of returning to function, ambulating, depression, and things of that nature are all greatly reduced following fractures. And so these are things that we want to reduce to have healthy, well-being lives. And the way to do that is, screening and appropriate treatment. most people, when you think of osteoporosis, these are the images that come to your mind. So we have the top panel shows our spokeswomen, our celebrity spokeswomen, and you see a lot of images of old, frail white women. And this is actually Google osteoporosis images, the top pictures that come up. But when you look at osteoporosis prevalence by race and ethnicity, you actually sort of see a different picture. So again, according to national estimates, the highest prevalence of osteoporosis is actually in Asian Americans, followed by Hispanic Americans, white Americans, and then Black Americans. But for me, and why I got interested in this field, is that this is the picture of osteoporosis for me. So this is my grandmother. The picture to the left is her when she was 65, strong, standing tall. And this was a picture of her last year, 97. She's turning 98 this year. And have watched her basically dwindle to this still a strong Black woman, but frail and losing bone. And so it is important for me to stay in this field so that this doesn't happen to my aunt and my mom and me and other women of color. So hope you all enjoyed the rest of our panel and looking forward to your questions.
Dr. Wright, there are going to be a couple of questions coming your way for sure, from me and from the audience. Thank you very much, not only for giving us that presentation, but for also telling us a bit about your own personal story and how you arrived at your research interests. I want to turn it over to Taylor. And Taylor, if you can talk to us about the data and the significance of the data around osteoporosis, especially given that Dr. Wright just laid out the importance of connecting fractures to falling or and to overall health and life quality.
Sure, thanks. So yeah, I want to go ahead and share our index with everyone. So let me go ahead and share that. All right, okay. So what we're seeing here is the osteoporosis and hip fracture index that we have actually made public in partnership with Amgen. So this is publicly available. It does not require credentials, and it can be accessed simply by going to osteoporosis.nmqf.us. So if you go to this URL in any web browser, you will see what I'm looking at here. But this is our index, and I'll try and give just a real quick overview of what we're seeing here. So right here, we're seeing nationally, we're looking at Medicare fee-for-service beneficiaries for the year 2016. So I can select this arrow here on the left and we can see what we're looking at. So there's a number of filters that can be applied to the data. And if at any point you're unsure of, what am I looking at right now, you can pull out this side panel and this will show us what we're seeing here. So again, these are patients from the Medicare fee-for-service for 2016. The condition we're seeing right now is osteoporosis. And then down below, this is just telling us that all of our demographic groups are currently being mapped. So collectively, nationally, we're seeing 2 million beneficiaries nationwide here with an average prevalence here at just over 5%. So I'm going to go ahead and if I open my filter panel here on the top left, I'm going to just go ahead and change our condition. So these are the three primary conditions that we can use. Osteoporosis is the default. I'm going to go ahead and for this, we're going to look at DEXA scans. So I'm going to go ahead and apply DEXA scans, and then we'll get that showing nationally. So there are a number of geographies by which we can aggregate the data, and the default is zip code level, which is our most granular geography. But there are a number of other geographies we can choose from here. So we often use 3-digit zip code, which is a slightly less granular geography using the first 3 digits of a zip code. But then also you have, state MSA, we have congressional district, and we do also have the upper and lower house districts as well as options. So we'll go ahead and take a look at this by zip code for DEXA scans. And so here we have the DEXA scans showing. So here we're seeing about 2.5 million beneficiaries for DEXA scans, prevalence rate about 6.3% there. So the way that the legend works here quickly is, regardless of which geography you're using, the index will take all of the geographies and evenly distribute those across 7 ranges. And so that's what drives these ranges down here below in the legend. So I'm going to go ahead and quickly, we're going to hone in on some things here. I'm going to go ahead and switch to 3-digit zip code, and then we can do a comparison of the non-white population versus the white population. And so we can do that by this arrow here. If I select this, we'll actually open up a second window, and this will apply the settings that we've selected. And so for right now, the changes that we've made are we've selected DEXA scans as our condition. We're using 3-digit zip code. And so in the first tab, I'm going to go ahead and filter by race. And I'm going to go ahead and make this our non-white population and apply that. And then I'll go to our other tab, and we can go ahead and filter, and we'll make this the white population. And so we can get a side-by-side comparison across the two of these. So for comparisons here, we can see we're dealing with about 330,000 beneficiaries for the non-white population, with a prevalence here of about 4.5%. If we switch back to our view where we're looking at the white population, we see we have about 2.1 million and about 6.5% prevalence, so about 2 percentage points higher. If we scroll down, we can actually look at we have some demographic pie charts that will show nationally the demographics of those that we're viewing currently. So we can see that it's a pretty overwhelmingly female group. And again, this is specific to the Medicare population. So that being the case, and this being osteoporosis, it is going to be predominantly over the age of 65 here. But we can see that we have 100% white as we've filtered on that. And so if we do a comparison side by side, one thing we see here, let me go back here, we can come down. We can see that the age ranges here actually for the non-white population skews a little bit towards the younger side. So we have, these are about 4 percentage points lower for the over 80 and the 75 to 80 group for the non-white population compared to the white. And this is about 4% points higher. So if we go back and forth, we'll see that here. Yeah, so we have 17 and 21 versus the others. So that's a quick comparison we can do. We can also look at the ranges in the legend here and kind of get a quick sense of what kind of prevalence we're dealing with. So we can see that it's predominantly kind of in the 4 to 7% range here for the white population. We can see it's more about 3 to 5% in the non-white population. So these are some really quick ways to kind of see some differences in what we're looking at. And then additionally to this, we can change our view. So in the top right here, we can change from a map view to a table view. And so this is giving us the same data with the same filters in a table view, and we can now sort by any of these headers showing here. So if we want to see, well, what was that highest prevalence rate, and basically get a ranking of geographies by prevalence, then I can select this and we can see our top prevalence rate here is this 3-digit zip in Texas. So this is our top 10 ranking that we see here. And again, there's that national prevalence rate. And so we can switch for the white population to the same view, run that prevalence again. And here we can see a side-by-side comparison, seeing a lot of Texas and Florida here. Similar, a little more California in this one. And then another thing that we can go ahead and do is if we want to look at a specific state, we can do that. So I'll go ahead and just select Alabama, and I'm going to sort by zip code. And then I'm going to do the same in our other panel and apply that. So now we can specifically look at the state of Alabama by our geography we've chosen, and we can see okay, how do these individual geographies compare across our two groups? And again, we've got our white versus non-white population. So we can see for this 350 zip code, the prevalence is 7.7%, slightly over the national prevalence. Again, this is the white population, 4,000 patients having gotten DEXA scans. And if we look at this for the non-white population, see 540, you see that prevalence rate is at 5.2 compared to the 7.4. So this is a quick way to get in, start doing some comparisons. We can apply, various filters. And then the last thing that I'd like to point out is that we've got built into the indices some standard reports. And so I can select on the top right here, public access, and we've got view reports. So I can select this and we'll get a panel up here. The important thing to know here, I'm moving through this quickly, but select your condition here, right? So you can have multiple or you can just have one. And then you need to, on the show by, this is where you'll select your actual congressional district. So we can select Alabama, and then any of the congressional districts we want to see are given as options on our drop down. We can run that and it will download. And so I've already got that pulled up in another tab. So this is what the congressional district looks like. And this tells us that in the congressional district for Alabama 7, we're seeing that there are 1,800, about 1,900 people with DEXA scans in the congressional district. And then we can see the prevalence in the district compared to the national numbers, so 2.4 versus 4% here for the year 2017 in this case. And then we have a breakdown by race of how those numbers break down. So we see that here, mostly the white and the black population. We've got the breakdown by age. This is a view of the district here. And then we've got some standard tables below where you have the total number of beneficiaries for the district, those with DEXA scans, dollar amounts associated with that. And then we've got our standard tables for which we've got some information on hospitalizations and ER visits. And again, this is broken out by race, and we can see the dollar amounts associated with the inpatient stays. And then you can see the average cost per beneficiary for those hospitalizations. So we can see that these are a little bit different here, but not significantly between the white and the black population. Down here in the ER visits, we can actually see there's a much more sizable difference between the two. So this is also another great way to get right into the details at the congressional district level. And then we've got some cost statistics down below as well. So I know that's a really quick overview, but again, this index is public, so I encourage people to look at it. And of course, we're always happy to answer questions around this. So thank you.
Taylor, thank you. Immediately, I think to myself how useful it would be if staffers, particularly health staffers, could be trained on this data. So I may, in terms of really navigating the overall database from NQF, but especially when you're talking about specific areas that a lot of people don't know much about, this would be really helpful. So I'm going to take it upon myself to follow up with you specifically about that. I'm also going to have questions about the map. So we'll circle back, but I wanted to bring Shannon into the conversation. Shannon, I'm hoping you can talk to us a little bit about, or help us to make the connections between different things that are going on in the policy space, and talk to us a bit about testing with respect to osteoporosis.
Thanks so much, Mia. So I'm Native American, I'm Eastern Shoshone, and that's my tribal nation. I actually, when you're Native American, you really want to be called by your tribal nation, not by Native American, Indigenous, Indian. But one of the things that was interesting to me was Taylor's presentation was he showed that just over 8,000 natives had been tested. I was surprised it was that many, but my mother is one of the anomalies in the native population because she's been tested twice. She was tested once early on in her time in Medicare as part of the Welcome to Medicare exam. It showed she had osteopenia, which Dr. Wright showed was one of the kind of early stages of osteoporosis, and was treated and, started lifting her soup cans and all of the things she needed to do to build back her bone density. At the same time, we talked about prevalence based on race. We didn't talk about some external factors that impact populations and can lead to osteoporosis. Some of them being, cancer treatment, diabetes, and things like that. So, my population has a high diabetes incidence, and at the same time, lots of people are on dialysis, and both of those can contribute. And my mom had breast cancer, and she was tested before her breast cancer treatment and after her breast cancer treatment and treated for osteoporosis, which occurred because of her breast cancer. My mom is the perfect case of doing everything right. She fell, broke a bone in her hand. They tested her again. Like, those things just don't happen, especially in the Native population. Dr. Wright, I saw nod at me. And so, I have this family experience. My father was never tested. They don't test men in Medicare as part of the welcome Medicare exam. And he broke his hip. So, I can certainly see the difference in my own family. One of the problems is that the payment for the DEXA test has been going down and down and down. And it's, since 2006, declined 74%. And because of that, less and less physicians have been having the test in their personal offices. You saw how big that machine is. It's expensive. And the space for it is, takes a lot of money from the office budget. Because of that, people have had less access. You would, your mom or your aunt would go to the doctor, you would take a day off to take them. They would have their tests while they were in the office. The doctor would look at the results, diagnose them, treat them, and it would all be done in one fell swoop. Now someone needs to take that person to an imaging center or to the hospital, take a second day off work, and we just see that follow-up doesn't happen. Because of that, we've had so many less women tested. 5.8 less women have been tested. And because of that, we believe that 1.6 plus million cases of osteoporosis have gone undiagnosed. And for years, we've seen osteoporosis going down, down, down as DEXA testing went up. And all of a sudden, osteoporosis was going up. And as a result, hip fractures were going up and increasing the money to the system. Dr. Wright did a paper on this. So, getting this payment rate back up into a level where physicians can actually perform the test will be really important. There are two pieces of legislation in the House and the Senate that do just this, HR 3517 and S1943. They're both on the fracture prevention website, fractureprevention.org, fracturepreventioncoalition.org, which we'll put in the chat. But, it's really important if we want to have really good preventative care and stop diseases like osteoporosis, we have to pay for them and make them accessible. And when they're not accessible in the general population, we all know that in rural populations, on reservations, in minority communities, they're less accessible. So, our problems are all exacerbated. We're also losing a lot of doctors who used to practice bone health as well. So, this crisis is just getting worse and worse.
Shannon, you really laid it out for us. I'm going to start backwards with some of your comments in terms of a lot of the interventions on the policy level. It's not just with respect to, well, the biggest part is what you're talking about in terms of reimbursement for testing, right? You're also talking about pipeline issues in terms of getting future physicians to pay attention to bone health. You talked to us about the other factors, comorbidities that contribute to the decrease in density of bones, right? And then you also talked to us about the significance of testing at the nexus of race and ethnicity and gender, right? And when you were giving us a story about your father as well as about your mother, and then race and ethnicity with respect to minoritized populations and historically medically underserved populations in terms of tribal nations. So I really appreciate you walking us through each of those elements. I'm wondering if I can bring in, as I'm going to ask you another question, can you break down for us again why it's really important that DEXA rate testing is commensurate with really with diagnoses in terms of osteoporosis, and talk to us a bit more about the barriers to diagnosis. And then I'm going to bring Dr. Wright in to follow up with that.
I mean, I think the biggest barrier is there's just not enough places to get the test. It's not convenient enough. It's not accessible. You know, you have to go to the separate place. Someone has to take a separate, you know, appointment, whatnot. And, you know, we just know that in all kinds of testing, the more steps you have put into it, the less people are tested. It doesn't matter. You know, we see it in COVID. We see it in everything. We all know accessibility is the key and access is the key. But I will defer to Dr. Wright, obviously, on the tension between testing and a diagnosis, because she is our expert.
I mean, I would say I'd like to look at it if you start going back. And so, okay, if you will start from fracture. So how do you prevent a fracture? You would say, let's think of treatment. And then how do you get on treatment? You need to be screened and have been diagnosed with something to get medication. How do you then get diagnosed? You need a screening test. And so how do you get that screening test? A doctor has to, you know, order it. And so if no one is ordering that screening test for you, or you're not getting that screening test, then you're not getting those medications. And then therefore you may be, you know, not preventing fractures. And then all of those adverse events that can come from a fracture then could play out. And so that's how I like to think of it, why it's so important to start at the beginning and thinking about bone health and thinking about, you know, screening and protecting your bones at the beginning, as well as, you know, once you have, you know, if you happen to have a fracture and what to do then, but to thinking, okay, first we need to do the screening and making sure everyone has access to that screening. And I would say, and maybe this is sort of jumping the gun a little bit, but I was very glad to see the data that Taylor's showing. It's like you're seeing what is going on. There are, you know, a difference does not mean a disparity. There are racial differences in bone health, genetically based off of ancestry, particularly say people of African descent have higher bone mineral density. So yes, it may not be as much of a problem in the Black community. However, as Shannon was referring to, risk factors, diabetes, you know, other things that contribute to bone loss play a role. And that's where we need to start caring. Diabetes, cancer, all of the other comorbidities that may be more prevalent in our communities, that's where we need to start making that link between bone health. And so where we're not seeing, where those proportions are different in who's getting screened and not being screened, that's where now we could be getting into a disparities realm with respect to osteoporosis management. And it's not just, oh, Black people have better bones, therefore they do not need to get screened for osteoporosis kind of deal.
Yeah, I truly appreciate you breaking that down for us, Dr. Wright, and to go off of some of the things that you mentioned in terms of screening and testing. Are you, because I am, and correct me if I'm wrong, there aren't any standard protocols for, like, for instance, if you're at a certain age, then different associations will say that you should be receiving a mammogram as a woman at a certain age. Same with men who are more prone to prostate cancer. There aren't the same levels of protocols for testing for osteoporosis, or even for osteopenia, right?
So there are, you know, the National Osteoporosis Foundation has its guidelines, and it's basically 65 plus, or if you're younger with risk factors. The U.S. Preventative Task Force Service has its, you know, guidelines. Other organizations have their guidelines. I think it's the knowledge of these guidelines to primary care physicians, because bone health is one mostly taken care of at the primary care level. And so having that acknowledgement of, okay, this is something you need to do. And so when, say, Medicare put it in sort of the welcome to Medicare sort of package, like, oh, you're 65, we're just going to do this because it's a part of a service and it meets a national guideline, then let's do it. But it's not happening in everyone at the same rate. And so why? What's going on where we're not seeing that?
Yeah, I want to bring Taylor into this part of the discussion. Taylor, when Dr. Wright is talking about access and differential access and differential rates of testing, do the data that are available on the NMQF site help us to break down? I know these are Medicare data, so the testing is paid for, but where would someone go if they want to know about, paying for the test? And do we have the data that helps us to identify whether or not earlier testing is better, or helps to really get at what Dr. Wright is saying, which is, better outcomes?
Sure, yeah. So there's a number of ways to look at the data. And again, I think I pointed out there is some of the cost data in there. You can see the costs per beneficiary. So that is certainly available. And you can view, we have some statistics in the index on, again, the hospitalization rates and the ER rates and readmission rates. And so you can get in to the index and view some of those things.
That's really reassuring. And let me see. So actually, it looks like someone has their questions about vitamin D supplementation, and especially because Dr. Wright brought up bone density differences of Black Americans. But before we get to that, Taylor, I wanted to stick with you and ask if you wouldn't mind bringing up your map, the first map again. I wanted to talk about geographic differences. And the reason why I bring that up is because it didn't seem very apparent to me that there is much of a geographic disparity, if you will. Usually, like when you're talking about issues that map onto socioeconomic status, that map onto race and ethnicity, you will see large pockets, especially in the U.S. South, of prevalence. But this looks like really, how would you describe the pattern here, or would you describe a pattern geographically?
Yeah, so this particular view is kind of hard to pin down geographically. Again, we're looking at DEXA scans, and you can see how that's breaking down here. One thing that I found interesting, if we go to, I'm going to switch conditions to hip fracture, and we are still looking specifically at the non-white population at the 3-digit zip. But I did find this very interesting, and this really stood out to me. You can see how much Oklahoma, Arizona, New Mexico pop out here, which suggests to me this is the Native American population here at the highest prevalence rate. So that's something that really pops out when you're looking at the map for specifically for hip fractures.
So then I want to punt it back to Shannon here. Given a lot of what you were talking about in your opening, how would you suggest that policymakers and their staffers really consider this breakdown of the data? Because and why would having the granular data really matter? Because you wouldn't have seen this in the DEXA scale index.
Well, I think that part of this, as you can see from this map, is a little bit of the failings of the Indian Health Service and the fact that they need much more money in their budget. But we could do 5 webinars on that subject alone. But there is, this gets to the fact that, one, we need more education across all populations, but especially in communities of color about, and with lawmakers, we have, really worked on targeting offices actually in a lot of these areas with very specific data so that they understand that they have unique challenges. But I think we need to fix the system overall, knowing that, that will greatly benefit these areas. But this is, I think that, this is the exact example of our problem, right?
Yeah, can I just comment on that as well? And when looking at data, so first thing that sticks out to me, you're like, ooh, you see this red, and you're like, there's a problem. And then you start to look at the prevalence, and now you're looking at the numbers, you're like 0.38%, to 0.86%. And somebody may brush that off as, oh, that's not that big of a deal, particularly if you were to then look at the hip fracture rates or prevalence in whites, and it would be, 5-10 times as large. So you're like, oh, maybe we need to concentrate more on the white population. But then if you then mirrored that to DEXA in this area, and now it's really low, or medication use in this area, that's where then you start seeing, that's where the disparities again piece comes in. So although this overall prevalence is low because the hip fractures in Native American population, although it's actually really high, the number of people is low in comparison to white individuals. It is still a huge problem. And then the things that could potentially be mitigating this problem are probably not the same shade as what this is showing. And so I think this is, again, Shannon said it perfectly, a great example of something we could do better to have better bone health in these populations. And I'm sure of tailoring it to Native American, and I'm sure Black and Hispanic and Asian, you would see, particularly in certain areas like the Deep South and other areas, you would probably see similar things.
Yeah, you're both essentially talking about two different things. You're talking about the same things, but you're highlighting two things for the audience here. You're highlighting the significance of political prowess and also political will. And then what what Daniel Dawes talks about as political determinants of health, right? In terms of the ways in which communities are empowered through their representation, through the institutions that are supposed to step in and really be the voice on behalf of well-being, right? Irrespective of whether or not they're traditional medical or clinical institutions. In this case, we are talking about, you mentioned IHS, Indian Health Services, and myriad other institutions. But then we're also, on the other hand, talking about social determinants of health. And so let's bring some of that into the conversation as well. And one of our audience members was asking questions about nutrition, and maybe we can talk a little bit about the significance of nutrition, vitamin D, and other social determinants of health.
Right. So with respect to nutrition, calcium and vitamin D are the biggies that are well known. And it's important. So nutrition is one of those things of people think, oh, supplementation, but you do have a whole diet. So you have to remember you do eat food. And so to supplement based off of what you don't eat, supplements only work if you are deficient. And so if you have a diet that's low in calcium and you need to supplement, then take your recommended 1,200 milligrams of calcium a day. So then supplement to meet the 1,200 milligrams. With respect to vitamin D, it's around 800 to 1,000 international units. So again, looking at all the foods you eat and then supplement accordingly. For Black individuals, we typically do have have low vitamin D. And so there's a lot of these big boluses of 50,000 IUs kind of deal. So I'm not a medical physician, so that is something your doctor would prescribe, but keep that in mind with respect to supplementation. No need to spend the money on pills if you don't need to. Other things with respect to social factors, I believe it's not as well studied, but I would definitely say social determinants of health play a huge role in bone health. I would, things around transportation, things of getting at that access to care, things like that. That's a place where me and some of my colleagues, that's sort of our next step in our research of sort of figuring out the impact of those factors on bone health and what we can do to potentially if it's intervenable, develop interventions around them. And if not, at least acknowledge and bring to light the impact of those factors.
Mia, may I also add, one thing is our communities need to advocate for themselves. And, we can all talk about diabetes in Hispanic, African-American, Native American communities, right? We all know the impact. We all know, what our folks think about it. We all know people impacted, people who've had, limbs amputated, died from, heart disease because of their diabetes. We all know those things. No one talks about osteoporosis. We don't think it's in our communities. It's like Dr. Wright said, we think we have stronger bones, whatnot, but it really does impact our communities. But because we don't know about it internally, we're not talking about it. And I think that's one of the important things about today's discussion is we have to own this issue and talk about it.
I wholeheartely am with you on that. And I especially appreciate the fact that you all broke down the 3 different threats to the musculoskeletal system in terms of the earlier stages of osteoporosis all the way through osteoarthritis, and then it's the actual expression of osteoporosis. And I'm wondering then if you can talk to us about why younger people, those who are not within the quote unquote Medicare age group, why they should be concerned. And then how do we help for policymakers to really consider this to be a significant issue? And that's a question for anybody. I'll put it this way. When I was coming up, the big thing about bone health was drink your milk, drink your milk, drink your milk, right? And especially when you're talking about a lot of people who are Black will say, well, I'm lactose intolerant, so I guess I'm going to eventually develop osteoporosis. Not really considering that calcium dense foods don't just come from dairy products, right? So what is the communication by age level? What seems to really work?
And that's another area of research where, again, osteoporosis has been targeted primarily to a white audience. And so the knowledge, and I think as Shannon said, it's not something that people of color think about. And so you think of bone health, and so you milk and cheese and dairy and all these things that, where you're like, oh, but I'm lactose intolerant. Well, it's like greens, that's, a lot of calcium, and other, beans and things like that. So like, okay, if you're targeting, say, a Hispanic community, like let's try to promote the cultural foods that promote bone health in that community. In the Asian community, what can we do to promote bone health and highlight those things? In the Black community, what can we do to promote bone health that is more relevant than, just a picture of like cheese and milk? And so we need to do a better job of that. The patient advocacy organizations, I know National Osteoporosis Foundation and American Bone Health are doing a better job now of reaching out to specific communities of color and figuring out their needs and wants of how to present bone health information. And so I know that's something I've been working with American Bone Health with. So that's, again, in our area around prevention, that's something that we need to focus a little bit more on.
I completely agree with you on that. This next question is for Shannon and for Taylor. In terms of really helping to make the story plain for policymakers, oftentimes it's the story that matters, right? It's the personal story, but it's also the qualitative numbers, right? And so thinking about where healthcare is moving in terms of we're getting more and more into precision medicine. We're getting more and more into conversations about equitable care. What is the next step for osteoporosis related research and specifically data needs. And how then can we use those data to create a more vivid story to move policymakers' hearts and to move their minds in order to create legislation that speaks to what will be needed in 5 years, what will be needed in 10 years. What are the data needs there?
Well, I'll just say, first of all, we saw this so acutely in this experience with legislation to restore the payment. When we had a 2-year fix in the ACA to the payment rate, and for a while the numbers were kind of stagnant. They didn't really move. And, offices were like, oh, well, that's a problem. We understand your problem. But it wasn't until the numbers really started to decline and hip fractures started to tick up that members really started to get engaged. So you're absolutely right. And now we can show a very vivid picture, which is all on our website about the correlation between testing, diagnosis, and hip fracture rates, and then the cost to the system. I think that data, is incredibly important. I think what because we need that desperately, but I'll let Taylor talk to the other pieces.
Yeah, sure. And yeah, certainly using the data for research obviously is critical and needs to be done. But then also, we've put all the resources into the index that we have because, as you're developing a narrative and trying to communicate that to people, certainly having the images and having the maps and, having something really pop out at you, that's easy to communicate. And that's something people will remember rather than, simply just looking at a spreadsheet. It's good to have both. And so, we believe that the index hopefully can help in that effort.
I mean, to echo Shannon's words, this effort is tremendous, what NMQF has accomplished in terms of aggregating these data, and the fact that you can really hone in on the zip code level and on the 3 zip code level, and by testing, this is exactly the stuff that's needed. It's hard for people to understand. I mean, when you switch back, I'm quite visual, but I'm also an auditory learner. When you switch from the maps to the tables, right, and then back again, I'm pretty certain that many of us in the audience learned something differently through those data and in the presentation. And the presentation matters because we can talk until we are blue in the face about why osteoporosis is an issue that needs serious attention and specifically legislative attention. But with the visuals, with the stories, with the research, with the data, all of that plays a major role in terms of getting us to a space where we see appropriations matching with interventions, and interventions matching directly to the needs of the population. Speaking of which, the population is changing. We're seeing numbers about not only are we becoming a more brown population across the US, but we're aging and we're going to be around for a lot longer, relatively speaking, right? So then in that way, what are some other considerations that we need to keep in mind, especially because Dr. Wright, you mentioned that a lot of people are still under the impression that bone health is not the biggest deal when it comes to people with higher bone density.
Right, and I think it's an interesting, one of the questions in the Q&A box is around that fact is that what are things we need to consider, since this definition was based in 1993, right? One of the big conundrums right now in the field is, what are we basing this reference population on? Why are we referencing this to young, normal white women? Should we have a different reference population? Should Blacks be referenced to Blacks? Should Asians be referenced to their own, that sort of thing? Should the reference population be updated because it was from 1984 to 89? Bone densities have changed over time. Do we need to update that reference? So things like that do we need to consider that in the field to account for changes over time, just the natural history of bones, given our modernization in societies, as well as changes in demographics, the admixing of people, if you will, and knowing that race is a social construct. We don't need to group ourselves in these finite categories. And so maybe there's a different way of doing this that will get to individualized risk a little bit better. So that's one thing the field is grappling with. And I would definitely say, particularly for me, why it's important to be focusing on communities of color is that, as you did say, they are the fastest growing communities in the older US population. And so although, again, the hip fracture rates in Blacks and Hispanics may be low in comparison to whites, it's not zero. And so if that population is growing at a faster rate, then we could be seeing outcomes that we haven't experienced in a population. And so do we have the resources in those communities to take care of that? And I think COVID was a nice example of seeing where, our hospital systems were not ready for some of these things. And so if now you're in a community that's predominantly Black, predominantly Asian, do they have enough beds in the geriatric ward for hip fractures? Do they have enough people who are trained for these type of operations? Do they have enough physical therapists? Do we have enough, things like that? And so that is, for me, why it's important to keep diving into this work, to keep, the data. What do the data show? What do we know? And then again, how do we get the information to people? And I think one of the things you said, Mia, about advocating, that people need to advocate for themselves. And for me, that's where education comes in, because your doctor's not going to do it. By you having that information, then you can advocate for yourself that this is something that I need to do.
And can I just add one thing to what Dr. Wright just said? Because she said, do we have enough people? We don't. We've lost over 10,000 doctors who were diagnosing and treating in their offices for osteoporosis since 2007, which is over 40% of the physician population who was diagnosing and treating for osteoporosis. So, when we've lost over 40% of our doctors, we know we don't have enough now. We don't have enough for this continuing aging and, population. So that's part of our crisis too.
You hit the nail on the head. Again, it's not just straightforward. This is the issue. This is how you treat it clinically. There are other political and social issues that truly matter. And I appreciate you all being so thoughtful in terms of helping us to think through these issues. We have a couple minutes left. I want to offer to you all the opportunity to give us any closing words or even closing questions that you want to leave with us to think about until we're next able to gather. So Shannon, let's start with you. Any closing remarks?
I think my closing remark was the fall in the doctors. I defer to Dr. Wright and the others, but thanks you all for being engaged.
Thank you.
I would say, thank you to the organizers for hosting this. Again, osteoporosis is typically not on everyone's minds. And so bringing more attention to bone health is needed. And I appreciate the opportunity to talk about this.
Thank you, Dr. Wright. Taylor?
Sure, yeah, and I would just encourage people to, engage the index and engage the data, get in there and, kind of play around with it, because getting feedback from people, that's how we learned as well. And so we can't do all the work ourselves. And so it's helpful to us when we have other people getting in and taking a look at it. And so I would just encourage people to do that.
The nerd in me is so psyched about the opportunity. So yeah, I'll be heeding those words. But finally, thank you to Dr. Nicole Wright, again, from University of Alabama, Birmingham, Epidemiology Department. Thank you to Taylor Stair, Data Analyst, and all things handler with respect to the infrastructure resources at NMQF. Thank you. Shannon Finley, thank you so very much for all that you brought to us in terms of your 2+ decades working in this world that brings together policy and medical issues from Capital Counsel LLC. I'm Mia Keys, and now I will say usually I would say I'm with AMA, but this is my first time being able to say I'm back with Congresswoman Robin Kelly. And I'm very excited to continue these conversations in the future. Brendan, I'll turn it over to you, and thank you for the opportunity.
Oh, no. Well, thank you, Mia. Well, thanks everyone for sharing your knowledge today. It was really insightful and delightful to just sort of learn a bit more. And then even though I work at NMQF, it's always good to get a refresher on the index, Taylor. So I appreciate you and the work and your team is doing. One thing, if you have any questions, we'll be putting this webinar on our YouTube page and our NMQF page, so you can always refer back to it if you have any questions or any other concerns. And then additionally, Shannon Nicole Taylor, if you wouldn't mind, could we share your information with folks if they have questions as well?
Absolutely.
Okay.
Sure.
Definitely.
All right, great. So we'll definitely in that, we'll put your email addresses at least somewhere in the program so folks can contact you if they have more questions or they would need a little more insight on this issue. So once again, thank you for your time, and we look forward to seeing you next week. Mia will be joining us again as we talk about global health. So I look forward to seeing everyone next week, and have a good weekend.
All right, thank you.
Thanks,
Thank-
everybody.
That.